My name is April Kyle, and I serve as the President and CEO of Southcentral Foundation. I am Alaska Native and Russian on my father's side from the village called Ninelchik, and so I'm a customer owner in our healthcare system. Southcentral Foundation is a regional Native healthcare organization, and our story began with a government-operated healthcare system called the Indian Health Service. And we as Alaska Native people gained the right to contract those federal dollars and own, operate, and design our own healthcare system. And so this is the Alaska Native owned healthcare system and how we changed it. We set up our system based on 3 core values. The first is this idea of customer ownership. What does it mean for a community to own its healthcare system? The second is that wellness is multidimensional. So each of us right now has physical, mental, emotional, and spiritual wellness, and that those things are all connected. And if you believe that, it changes how you design a healthcare system. The third is relationships. So we believe the core competency of our system, the thing we're designed to create, is quality relationships. And that's at a macro level between healthcare system and community, and then every day at a micro level between care teams and families. And we'll talk about how that works. We've designed a really robust primary care system. We launched advanced access, same-day access, something like 20 years ago. We integrated master's level behavioral health clinicians on integrated care teams 15 years ago. And we now have in primary care integrated psychiatrists, pharmacists, pediatricians, midwives, dietitians. The idea is that we want to leverage the longitudinal relationships that we create between care teams and family, and then bring all of that expertise around that relationship. In addition to primary care, we know that people need more than that. And so we have a continuum of services that includes mental health, addiction, elders, youth, community interventions, all of the things that we know impact wellness for community. It's a great philosophy, but the proof is in the measurement. And so since we've redesigned our system, we've had 45% less ER visits, hospitalizations, and we're consistently hitting 75th percentile in primary care outcomes measures against comparators. So how has that played out during COVID? I would say that we started COVID with these relationships already in place. So in every local community, we have a health council, and that health council is made up of family members from that community, and they are the on-the-ground governance of their local healthcare system. And we began meeting back in March, hours and hours with each of these health councils. And the system brought our expertise. So what do we know about the virus, the science, and how it spreads? And community brought their wisdom and expertise. What were they worried about? How did they think this was going to impact elders and youth and multi-generational households? And how are they going to do quarantine? We talked about masks and distancing and travel rules and how you would do isolation and how we would do care delivery. And we planned together and we implemented those plans. And then 2 or 3 weeks later, we would check in. We would know more about what the World Health Organization was saying or the CDC. And we would say, well, we know this now. Masks are really important. The kind of mask you wear and how you wear it is really important. And we would plan with community, and community would say, we're worried about this. We need more mental health. We're worried about our youth. And we would adjust our care delivery based on those relationships. At the same time, we were planning at a micro level between care teams and families. So think about a primary care team or even an addiction care team who's already in a relationship with a person or a family. And they met and said, you know, we have been meeting in person, but now we have COVID and we have all these other tools. How do we want to approach this? Do we want to meet in person? Do we want to try video? Are you more comfortable with phone? Should we meet individually or should we come together in groups? How much should we do by distance, and how often do we really need to meet in person to make sure that we continue good clinical care? And so we created sort of the toolbox of options that those primary care teams and families could choose from in order to co-create their individual paths forward. So in conclusion, I would say that when COVID hit, we were sort of set up, already owned by our community, in relationship with our community, and thinking about not just the physical wellness, but multidimensional wellness. And that set us up to really plan and implement interventions that were what our community really needed. So thank you for listening to our story. Have a great day.